Hi guys, the next topic that we are studying is sickle cell anemia. The first case of this was detected way back in 1952 at the foothills of Nilgiri Hills in Tamil Nadu. At that point of time, the diagnostic facilities were very limited in our country, and publishing it in international journals was all the way still more difficult. So, hats off to those authors who actually documented sickle cell trait and anemia prevalence in our country, and then they created a map which you are seeing at the moment. And well, what is the importance of seeing this map is that you will notice that in all the parts of the country where malaria incidence is more, sickle cell trait is also found, or sickle cell anemia is also found to be in higher prevalence in those areas. You guys are very well aware of the fact that sickle cell trait per se is protective against development of malaria. So I would call this a evolutionary development in Indian genetics, that sickle cell trait has been prevalent especially in the southern and the central parts of the country. But if you look at the states like Jammu and Kashmir or Himachal Pradesh, very limited or hardly any cases are found. Now, once we have gone through this basic data, I would like to highlight regarding what is the main problem that will be occurring in this person apart from anemia. Because you see, we know that there is hemoglobin S which is defective, so that's understandable. Anemia will be there. But at the same time, I want to highlight that the main problem of these patients is that hemoglobin S tends to polymerize. Now, due to this polymerization, the red blood cells tend to become rigid, and these rigid RBCs will then get trapped in the splenic capillaries and they might get destroyed at an accelerated rate. Therefore, even in this condition, I'm using the word extravascular hemolysis, which is explaining the fact that there would be anemia occurring in this case. The previous examples of extravascular hemolysis that I have taught you are thalassemia and hereditary spherocytosis. Another problem that can be experienced is that if you imagine this to be any blood vessel in the body with a terminal branch, so RBCs in this condition also tend to become relatively more sticky thanks to again hemoglobin S. Now, because the red blood cells are relatively sticky, there's a distinct possibility that they might actually just clog up this circulation at the branching point, cutting off the blood supply to the distal areas. And therefore, the bad news is that this particular disease will be associated with multiple micro infarctions occurring in various organs. And one of the organs that is vulnerable to this would be the spleen. This explains why you read about autosplenectomy in this condition, because gradually the spleen gets destroyed. And the bad news is, if you are going to have an autosplenectomy in this case, usually by the third birthday, then this child will become susceptible to opportunistic infections as well. And this will also explain why, when I describe the clinical symptoms of this patient, I will mention fever as one of the primary complaints, followed by bone pain. Well, why bone pain? Because you can understand that the blood supply of the bone, especially the small bones of the hand, can be compromised. Every bone has a nutrient artery, no? So the terminal branches of the nutrient artery are getting clogged, or there's micro infarctions occurring in the bone. And the bad news is, if you have a avascular necrosis developing, then the bone pain in these patients might be so bad that they might actually become addicted to opioids. I want to highlight the fact that MCQs of this topic will either begin the American way by mentioning a Afro-American child. Either he will talk about African child, Africa malaria is common, or Afro-American child, or from Indian domain, he will talk about a child from mainly the central states or southern states of our country. So most of the time, this would be a tribal child with the manifestations that I will explain to you. The disease manifestations in this particular case tend to occur after 6 months. We do not have presentation in the first 6 months of this particular disease. Why? Because fetal hemoglobin has been shown to protect from the manifestations of the disease per se, because fetal hemoglobin is protective at the moment for the initial 6 months. Therefore, pathological jaundice will not be found in sickle cell anemia. When I discussed hereditary spherocytosis in the lecture prior to this one, I mentioned that the earliest presentation hereditary spherocytosis can be a child presenting right after birth with pathological jaundice with requirement of phototherapy and sometimes even an exchange transfusion. But because fetal hemoglobin has a protective effect for the first 6 months, so at least this disease will usually manifest after 6 months of age. So I can highlight this fact. Would be no mention of any pathological jaundice per se in a MCQ of sickle cell anemia. Let's summarize what are the clinical features that you will encounter over and above the anemia component. As I said, the prevalence of infection in these patients will be increased because the spleen is having these micro infarctions and is gradually getting destroyed. In fact, I can put a question to you here. Is the splenic infarction painless or is it painful? Well, all organ infarctions are painful. If MI is going to be painful, even the splenic infarction is going to be painful. So you will also read about acute abdomen and also left upper quadrant pain that might be misdiagnosed either as pancreatitis or maybe something related to renal etiology. But the bottom line is, guys, that in patients of sickle cell anemia, there's a distinct possibility that these patients might be presenting with acute abdomen as an initial presentation. Fever and bone pain will then be found on retrospective history. The reason for bone pain, as I explained to you, is avascular necrosis of the bone because the nutrient artery of the bone and its branches are having these microinfarctions or having these micro clots which are causing the cutoff of the blood supply. The term that he might use in the MCQ, because if he writes bone pain AVN, it becomes relatively easy for you. So he might write the word hand and foot syndrome, or he might write the word dactylitis. Now, why this term hand and foot syndrome is important is because you read about one is hand, foot and mouth disease, right? But then you read about hand and foot syndrome even in pharmacology with respect to anti-cancer drugs that I'm writing before you. Just a quick revision for pharmac for you guys. 5-fluorouracil and capcitabine are drugs that you read with respect to hand-foot syndrome. I'll show an image of that subsequently. Please do not confuse this with exanthematous disease where you would be having vesicular lesions on the hand and the sole of the foot and on the palms of the patient and inside the mouth also. So hand, foot and mouth disease is what you read with the Coxsackie A virus. I've taught you Coxsackie B being responsible for fulminant diabetes, even possibility of viral myocarditis, but Coxsackie A is related to hand, foot and mouth disease, and they would be rather vesicular lesions that you should not confuse with that of chickenpox. Coming back to the main agenda, I want to highlight the fact that if he gives terms like fish vertebra, let us take this to be representation of the body of the vertebra. This is the intervertebral disc, then another one in these patients, because the blood supply of the upper part and the lower part of the body of the vertebra can be hampered. So there is a possibility that he might actually give you an x-ray in which the shape of the body of the vertebra may be different from what is actually present, and therefore if this word is given fish vertebra, then you are more comfortable that he's talking about sickle cell anemia in this tribal population chart. Because of the destruction of the bone, there will also be some reactive changes. So if he says bone within a bone, that again is highlighting the reactive changes and the sclerotic changes that are occurring with respect to the avascular necrosis component. All of these terms that I've highlighted basically help you in identifying this presentation of sickle cell anemia, and the bone pain can be so bad that you will have to regularly use opioids. Due to bone pain, there would be high incidence of opioid addiction in this particular cases, and even getting opioids without a doctor's prescription will be difficult for these poor tribal parents of this child. If you contrast this with the discussion of thalassemia, I have highlighted a different change. In thalassemia, I said there is going to be an expansion of the bone marrow, and the radiological finding that I mentioned is squaring of the metacarpal. So get both the perspectives right. Squaring of the metacarpal is a radiological finding on X-ray of the hand of a patient with thalassemia, whereas in sickle, you might be having a lytic lesion, you can be having a bone versus a bone lesion, or you might just say the word dactylitis per se. So these are two important features which you need to remember, and the investigation choice for avascular necrosis happens to be ideally an MRI because initial changes may be not visualized on a routine X-ray. The third presentation in this condition can be acute abdomen. Why? Because this child is having a splenic crisis, and the reason for that is that the blood supply for the spleen is getting hampered. Lots of time there might be a misdiagnosis of this child who's having a left upper quadrant pain as either pancreatitis involving maybe the tail of the pancreas, or maybe you might think it's pain coming from the kidney. So you might think it's a renal colic. But it is later that is found that this child will be having a splenic infarction on a recurrent basis. Every time there will be a hospitalization of this child. He will obviously be given or dispensed painkillers parenterally so that the pain tends to resolve, and maybe in the first case or the first presentation of this case, the diagnosis of splenic infarction may never be made. Most of the time in India, there is a high probability that these cases with repeated hospitalizations might develop autosplenectomy by 3 years of age, and now this child is vulnerable to capsulated infections. The infections which are common in this case would be pneumococcus, meningococcus, and Haemophilus influenzae. This is not the end of the story. This is just the tip of the iceberg, because now these micro infarctions could develop even in the coronary artery and its branches. Like the terminal branches of the coronary arteries are called as coronary perforators. And if coronary perforators are starting to get blocked, then not only can this child suffer from chest pain, but because of this ischemic damage continuously to the muscles of the heart, because ultimately the small blood vessels are getting involved, even dilated cardiomyopathy can develop in these patients. The term that he will use to describe this manifestation in MCQ will be written as acute chest syndrome. I don't want you to confuse this with an alternative term that is called as acute coronary syndrome. You see, acute coronary syndrome is a term that you use when person is having atherosclerosis in the main coronary artery, that is the epicardial ones, and then there could be a thrombus formation causing MI or prinzmetal angina or unstable angina. Acute chest syndrome as a terminology is mainly for representing the sickling crisis that can occur in these patients. It is mainly to represent the micro infarctions that can occur in these patients, and therefore even cardiomyopathy findings like pedal edema or elevated JVP or maybe a palpable liver due to right ventricular failure could be described in this case. The pulmonary artery of these patients will also be impacted because of the vaso-occlusion caused in the small branches of the pulmonary artery. There would be a development of pulmonary artery hypertension. So an auscultatory finding or loud P2 can be written in an MCQ of sickle cell anemia. Even the kidney will be affected. The area of the kidney that is usually affected is the papillae. Papillae is those areas where ultimately all the collecting ducts are opening. So there would be a papillary necrosis. In fact, there are multiple causes of papillary necrosis. Sickle cell anemia is one of the important ones that is asked. Before I go forwards, I can use this opportunity to mention a mnemonic before you by the name of postcard, which is usually used by you in the exam to answer causes of papillary necrosis. Here, alphabet P would stand for pyelonephritis, which would be having WBC casts in the urine. Alphabet O would stand for obstructive uropathy. Now, there are various causes of it, ranging from benign prostatic hyperplasia to bilateral strictures. S would stand for the topic that we are studying, that is sickle cell anemia. CA would then stand for chronic alcoholism. That is what is usually forgotten by people. R is renal vein thrombosis, again a neglected part, and D is diabetes mellitus. So I would also like to use this opportunity to just make you remember postcard mnemonic for other causes of papillary necrosis. I want to highlight the fact that in sickle cell anemia, the manifestations that occur actually are beyond the anemia component. You could even be having stroke if CNS manifestations will develop. It could be coronary circulation getting affected, but most of the time the question will always begin by describing a tribal child, or let me say Afro-American child with starting with fever, then bone pain manifestations, which will be very descriptive, repeated hospitalizations for acute abdomen, requirement for opioids, development of opioid addiction, and then other manifestations of cardiac or pulmonary manifestations given in the question will help you in identifying that the question is based clinically on that of sickle cell anemia. Before I move on, I can also just show you an image-based question. In this, I have deliberately not included image of a patient, but just highlighted vesicular lesions present on the palm soles and inside the mouth with a history of fever of 2 or 3 days is hand, foot, and mouth disease. Whereas my next patient is receiving chemotherapy. You can notice some desquamation occurring. You can notice the redness and the erythema in the palms of the patient. This is hand and foot syndrome that you encounter with capecitabine and 5-fluorouracil. So hand and foot syndrome term is read both in sickle cell anemia literature and then also in pharmacology with the anti-cancer drugs. The subsequent manifestations of sickle cell anemia that I'll explain to you have actually also been discussed in the literature of hereditary spherocytosis. Because it is a hemolytic anemia, there would be an increased incidence of gallstones. The type of gallstones that would be seen here would be the pigmented variety. Obviously, he will ask you whether it is a black stone or a brown stone. I have already sensitized you in the hereditary spherocytosis discussion that brown stones are seen with infection, and it's the black stones that we're talking about here. The next manifestation that can occur is development of a non-healing ulcer. Now, traditionally, we read about non-healing ulcer over the medial malleolus in a person with prolonged standing with respect to a venous ulcer. But if you read a non-healing ulcer in a pediatric case, especially over medial malleolus, then two hematological conditions that I've highlighted are hereditary spherocytosis and sickle cell anemia. Then there could be problems caused by human parvovirus B19. It can contribute to development of aplastic crisis. Please remember that aplastic crisis and anemia are two separate things. Aplastic crisis is caused by human parvovirus B19. Yes, the same virus which is responsible for causing focal segmental glomerulosclerosis and even slap cheeks appearance in a child with a viral exanthema, that is erythema infectiosum, which can also be written in questions as fifth disease. These are the usual profiles that would be present in a patient. Now, before we talk about the workup of these patients, I just want to highlight some very specific features of this particular disorder. First of all, remember that X-ray skull showing a crew-cut appearance can not only be seen in thalassemia but can also be seen in sickle cell anemia, because in both of them, the bone marrow is frustrated. The cells that are produced are having a defective protein component in the form of hemoglobin S, which is over and above the traditional hemoglobins which are present, and that hemoglobin S is making the RBC sticky and simultaneously making them rigid. So ultimately, anemia is making the bone marrow react by causing a bone marrow expansion. So you will be having this classical hair on end appearance, or also called as crew cut appearance, which is very traditional terminologies, and I have not seen anybody mess up on that. But don't be surprised if you read about a case of a tribal population or a tribal kid who's obviously having all the manifestations that I have described, and he developed or he woke up with sudden onset hemiplegia. That is because his cerebral circulation is the one that is affected, and you can definitely notice a hypodensity which is present on one side. So acute ischemic stroke is also, though it's rare, but the point is there is a distinct possibility that acute ischemic stroke can also develop in a patient of sickle cell anemia. I also want to highlight the particular shape of a sickle RBC, which is gonna be like this, in contrast to what is shown subsequently, where the RBC is having slightly a different shape. This particular RBC that I've highlighted is what is called as a schistocyte, or is also called as a Helmut cell, and we read about schistocytes in multiple other conditions. Even in the kidney section, I have talked about hemolytic uremic syndrome, thrombotic thrombocytopenic purpura. These are separate lectures. We read about schistocytes in conditions having microangiopathic hemolytic anemia. So whenever in a peripheral smear you are given schistocyte versus a sickle, because both are having this particular appearance, both might be having a appearance that might appear to you like a sickle, right? This one is obviously not sickle. You can see the pointed ends, and then you can see, just a beak of a bird is there. You can see a small beak also present. So the appearance of a schistocyte or Helmut cell is grossly different from that of a sickled RBC. These are some manifestations that can be encountered in these patients. I also want to bring to your notice the fact that what I have described is sickle cell disease, but in fact, in the exam, he can talk about sickle cell trait also, and in trait, the manifestations will be lesser. If you will do hemoglobin electrophoresis of a person with sickle cell trait, you will be encountering 4 hemoglobins: fetal hemoglobin, adult hemoglobin, hemoglobin A2. But the extra thing over and above that is present in trait is HbS. So there are 4 hemoglobins present. In disease, however, you will notice that there is no hemoglobin A. Please appreciate the fact, I want you to remember this fact, that in trait there are 4 hemoglobins present in the body of the patient, whereas in sickle cell disease hemoglobin A is missing. So that is why the manifestations are more severe, because the normal thing is not there. When it comes to the left hand side, the trait patient, in a trait patient, the symptoms that I've described may initially not be present, but they can be triggered. Now, how can they be triggered? Triggering can be occurring either due to hypoxia, that is pneumonia episode, or let me say diarrhea that will cause acidosis component. So in cases of sickle cell trait, an episode of pneumonia/diarrhea, which will contribute to hypoxia, diarrhea will contribute to acidosis, can again result in hemoglobin S polymerization, and the end result would be still a development of anemia and sticky RBCs, causing the problems that I have said before you, though the severity will obviously be milder as compared to that in the disease. The message is that sickle cell disease is obviously more severe, but it is only having 3 hemoglobins. I mean, normally when you read this casually, a lot of people have an impression that when there are 4 hemoglobins present in the body, that is the disease. No, it is 3 hemoglobins with absence of hemoglobin A. Please appreciate that the protective effect, the normalcy is not there on the right hand side. That is why the right hand side of this discussion will be relatively much more severe. I shall now be teaching you regarding how to work up a case of sickle cell anemia. Well, the standard investigations will obviously be done, like HB will be less, LDH will be elevated, the indication of hemolysis, and peripheral smear will be able to pick up the sickled RBCs. The third investigation that would be done is a reticulocyte count that would be found to be increased. A reticulocytosis occurs in all patients of hemolytic anemia. The only one where reticulocyte count can be lower as compared to the severity of anemia is thalassemia major. The word lower will always be in relative sense to the severity of anemia and thalassemia major. The best way to confirm the diagnosis would be HPLC, a high performance liquid chromatography. Do not answer hemoglobin electrophoresis. I repeat that again. It is either a gene sequencing that can be done, or for that matter of fact, a high performance liquid chromatography. First HPLC and then gene sequencing, both make more sense. I would also do an ultrasound abdomen in these patients to evaluate for the spleen size, because if the spleen has shrunken, I need to be giving vaccination to this kid. Hypersplenism can also be a presentation in these patients initially. Do not be under impression that in all MCQs or all patients of sickle cell anemia, spleen will be destroyed. Spleen will be destroyed only if treatment is not given, and usually by the third birthday. Prior to that, maybe if the diagnosis is made at 1 year, there is a possibility that splenomegaly can be written in a question. So don't be biased towards the word autosplenectomy. Has to be written in a question to call it sickle cell anemia. It may not be there initially. It might be a splenomegaly because it's a hemolytic anemia, but subsequently as the disease progresses, that is when the size of the spleen will begin to shrink, and even hypersplenism could be a manifestation. Then radiological investigations will obviously help you. If you perform an X-ray of the hand of this person, you will answer dactylitis, whereas in patients of thalassemia, we have already discussed, they would be squaring with the metacarpals. Then words like bone in a bone appearance, or if he talks about X-ray of the spine of this case and mentions fish vertebra, then the diagnosis is given more credibility. You see, I'm not saying that 6 and 7 are diagnostic. I'm saying just that in a MCQ, more of these terminologies that I've written will help you know that he's going towards the diagnosis of sickle cell anemia. Now let's look at what is the treatment that you're going to offer for this patient. And the question that I'm putting to you is, can you tell me a disease from pharmacology that inhibits hemoglobin S polymerization? Because the basic problem of this chap is the hemoglobin S, which is created by replacement of glutamate by valine. You are basically familiar that hemoglobin S per se, that's very primitive information, but I'm still writing it for the sake of completion here. What happens here is that the amino acid sequences are changed. So glutamate, G for glutamate goes out. And when it comes to valine has a word in it. So valine comes in. Now, why are we so hell-bent on talking about this hemoglobin S polymerization per se? Is because this is the main event responsible for many manifestations that develop in this disease over and above the anemia component. So if I can inhibit the hemoglobin S polymerization component, that means that I will be able to treat these patients relatively better. The first drug that I'm going to prescribe to this chap is hydroxyurea. Well, traditionally we give hydroxyurea in patients having increased cell counts. Like if a patient with blood cancer is having very high TLC, 50,000, 1 lakh, I would give hydroxyurea to decrease the cell count. But hydroxyurea has one additional effect, that it increases the value of fetal hemoglobin, and this contributes to mitigation of manifestations, because you see, after all, the normal hemoglobins are present. Hemoglobin S is a total separate entity that's present in the body causing a problem. So if you try to spike to normalcy in the body of this patient, you won't be able to achieve normalcy. But I'm saying that if you try to increase the values of fetal hemoglobin in the body of this patient, mitigation of symptoms can occur. In fact, when I started this discussion, you would have noticed I was saying first 6 months fetal hemoglobin gives a protective effect. Right? I repeat that. I said first 6 months in sickle cell anemia, you don't have pathological jaundice because fetal hemoglobin is a protective effect. I'm just trying to replicate those initial 6 months of life. This is just going to buy me some time. Unfortunately, a lot of these kids will be having repeated hospitalizations for chest pain. It could be bone pain. So pain is what is bringing this patient to your hospital. So you will have to give IV analgesia, mostly using opioids. Give IV fluids to this patient. We will give fresh blood transfusion to these patients, but never answer packed RBCs. In thalassemia, I was talking about only packed RBCs, but in this case, if I will give packed RBC during a sickling crisis, it's gonna cause hemoconcentration. It's gonna worsen the patient. I repeat that again, guys. You see, there's a crisis. The blood supply is already sluggish because of the micro occlusions. If there's a sluggish circulation in the body and you give packed RBCs, the circulation will become more sluggish. That will worsen the patient. So don't answer packed RBCs in sickling crisis. It is fresh blood transfusion and fluids to get the circulation going. Well, what are the opioids that are used here? You can use any one of these depending on the requirement and availability. Fentanyl is available as a transdermal patch and has a very good efficiency, even better than morphine, so can be used. Others that can be used are like codeine, then can be oxycodone. In fact, the ones that I'm writing now, they still are relatively available easily as compared to fentanyl, which is relatively more expensive. So you will read about these drugs or prescriptions that you will see in your consultants in the hospital writing for these patients, which are mainly opioids. The last one that I'm mentioning is nalbuphine. I come to the core issue that I was asking you. This is the most important question from pharmacological domain for this particular topic, that what can you give? Because the first line that I wrote to describe this topic was HBS polymerization is the villain. Now I wanna prevent this from happening. So the drug that I'm gonna use in this case is voxelotor. This is a new entry which you just need to remember. Then monoclonal antibodies. I mean, I agree that if I teach you one more monoclonal antibody, you will say, sir, pharmacologist has taught so many, now you're introducing one more. So, I mean, do you think that this is important for the exam? So for 5, I'm not saying it's important. You can just listen to what I'm saying. Crizanlizumab is a monoclonal antibody. You see, monoclonal antibodies are the future of medical science. I mean, everywhere we read about abciximab, infliximab, natalizumab. So this is one more. If you can remember, great. Otherwise, let it go. This molecule, crizanlizumab, has been shown to reduce the frequency again of vaso-occlusive crisis that will occur in this patient. You are just doing vegetation of the disease, right? If there is a pulmonary artery hypertension developing, then you have to use 2 approaches. One would be phosphodiesterase 5 inhibitors that you use even in erectile dysfunction in males, that is tadalafil. And second molecule that you will use here is bosentan. So what he can do in the MCQ is that he can have 3 choices from medicine and 1 from pharmacology, where he might just say that endothelial, I mean, he's trying to incorporate pharmacology in the question. He will talk about endothelial receptor antagonist being given in these patients to treat the pulmonary artery hypertension of this patient, so that you can improve tolerance of the patient also, that is bosentan. Now, since it is important, we need to give protection to this patient against capsid organisms, so vaccines will be used. The vaccine we can use is a 23-valent vaccine, which is for pneumococcus. So the brand name I can write here is Pneumovax 23, or we can use Prevenar. Then is the Hib vaccine. Even if you don't remember the brand names, chalega, I mean, doesn't really matter. And then you will be using meningococcal vaccine. There are 3 vaccines effective against bacteria and 1 against virus, against the flu virus, that you would be giving to these patients. In elective splenectomy, I was teaching you that the vaccine should be given 2 to 4 weeks before. And meningococcal vaccine protects against the following serotypes, that is ACY and W135, but not against serotype B. The flu vaccine can be given by the nasal route. The next disease that I'll be explaining to you is glucose 6-phosphate dehydrogenase deficiency. This is an example of both extra as well as intravascular hemolysis. Well, how is that possible? I'll explain to you. But first, I want to focus here regarding the first slide that you can see and is greenish in color. There are 2 slides which will be given to you and the background will be green. One is the current one that is of interest to us. Well, this is a supravital stain that you have studied in pathology, and the name of that is crystal violet. You can see that the red blood cells are appearing green in color, and the bluish bodies which are present inside are called as Heinz bodies. The second slide that I've not shown at the moment, but you will notice that in the infection component subsequently, is pneumocystis jirovecii. The cysts on pneumocystis jirovecii will be black in color and the background of the slide will be green. So I just want you to remember that green slides per se that you see are 2. One is pneumocystis jirovecii, the black cysts, and second is going to be the bluish inclusion bodies that can be seen here and are called as Heinz bodies. In a standard HNE, the hematoxylin eosin stain, you definitely can pick up in this case the bite cells, which are standard histopathology findings of G6PD deficiency. Now understand what is the problem here. You see, in human body, free radicals are anyway produced, and the main function of this enzyme glucose 6-phosphate dehydrogenase is that it will neutralize this free radical, it will neutralize the oxidative stress in the body. The oxidative stress can be created by intake of drugs also. Like suppose when we take anti-malarial drugs, the anti-malarial drugs will kill the malarial parasite inside the RBC, but the oxidative stress that is generated, it will obviously kill the malarial parasite, but RBC does not get destroyed. Why? Because we have a safety feature, we have a security feature by the name of glucose 6-phosphate dehydrogenase that can neutralize the oxidative stress caused by drugs or naturally occurring in the body. You see, traditionally, if they do not mention anything and they ask for a single best response saying what type of hemolysis is noticed in G6PD deficiency, your answer would be extravascular hemolysis. However, sometimes there can be triggers which can contribute to intravascular hemolysis in this condition. One can be consumption of fava beans. The second is consumption of anti-malarial drugs. In fact, from the Indian perspective, we will mostly describe a patient who has been diagnosed with malaria, and when this drug was given to him, he actually had a renal failure. Let us understand why a patient who is being given anti-malarial drugs is suffering from renal failure. Well, hemolysis occurs not only because of malaria, but will occur due to G6PD deficiency also, because in this case, when you prescribe anti-malarial drugs, the oxidative stress, the RBCs will not be able to handle it. As a result of which, since the hemolysis will contribute to generation of free hemoglobin in the blood, I'm using the term hemoglobinemia. You see, hemoglobin should be inside the RBC, not roaming around free in the blood. So now this will get filtered via the glomerulus into the tubules of the kidney, and this person will start passing a black colored urine. The relatives will blame the doctor saying that your drug has caused an adverse reaction and the person is passing a black urine, and the patient might even die because of acute tubular necrosis. Please appreciate that hemoglobin per se as a product can block the tubules of the kidney. They have asked this question in the exam, what is the reason for death in G6PD deficiency? Your answer would be acute tubular necrosis. What really happened here was that unlike a normal individual whose RBCs can handle the oxidative stress, here the RBCs were vulnerable, so they just burst. The bursting is because of two reasons. One, obviously, malaria will cause bursting of RBCs, but that does not mean renal failure, na? In this case, the reason for renal failure is extensive hemolysis, which occurred post anti-malarial drugs, and the patient is passing a black color urine. And therefore, I would like to highlight the fact that lots of time unnecessary medico-legal litigation can be present against the doctor. In America, this can be definitely prevented because they routinely do G6PD assay in all babies. If G6PD assay shows G6PD deficiency in an American child, the parents are given a proper printout telling that if your child ever goes to a pediatrician in future, if he writes whatever drug to your child, you need to show this card or you need to show this printout to the pediatrician so that he is aware of the fact that your child is having this deficiency, so that he does not write drugs which can trigger hemolysis. In fact, there's a dedicated website in which parents can just key in the brand name. They don't need to even type in the salt. They just can type the brand name of a particular drug, and the website will tell them whether this drug is safe for their child or not. But obviously things like these would not be possible in India. There are a lot of drugs which are contraindicated in G6PD deficiency. I'll try to mention ones which are clinically relevant. One is aspirin. Then is a urinary antiseptic, that is nitrofurantoin. Then is anti-malarial drugs. All the standard anti-malarial drugs like primaquine, chloroquine, mefloquine, they are contraindicated in a case of in a patient of G6PD deficiency. So while I'm writing it, I can just pose a question to you guys. Can you tell me an anti-malarial drug which can be safely given in G6PD deficiency? The drug that can be given safely in G6PD deficiency patients, even when there is a malaria component present, is artesunate. but you are not supposed to give the standard ones. So I just want you to remember this information. The basic concept, guys, which I'm trying to give you is that triggers will contribute to intravascular hemolysis, and otherwise it is extravascular hemolysis that is occurring in these patients. So actually, in a question, if they give you multiple correct options, then this is one example where both extra and intravascular hemolysis is occurring. Routinely it is extravascular hemolysis because naturally in our body also there is oxidative stress. Naturally in our body also oxidative stress has to be neutralized. G6PD deficiency is not going to be ensuring a normal survival of the RBC. So I'm just saying the word extravascular, but in case it's going to be some drug induced damage, then we will say it's an intravascular hemolysis, and therefore haptoglobin levels will be totally absent. Well, how do you differentiate between extravascular and intravascular hemolysis? A blood test that I just mentioned was haptoglobin levels. You see, haptoglobin levels can be low in extravascular but never absent. Haptoglobin is like a mop that will bind to free hemoglobin. Whenever you read serum haptoglobin is absent, because it has been consumed. It is like a mop, it is consuming the free hemoglobin. The consumption will result in absence, and therefore remember question wise that what blood test can be used to differentiate extravascular versus intravascular hemolysis? It is serum haptoglobin levels. The topic is relatively an easy one because as such nobody will make a mistake in picking up crystal violet stain, Heinz bodies or Bite cells. So most of the time he will try to trick you into commenting on whether it is an example of extra or intravascular hemolysis. It is both. And why do you have death? Your answer would be acute tubular necrosis in the patient. A related slide that I would definitely like to highlight, though I've done that earlier also, is a red blood cell which is having this basophilic round inclusion present. So I'll just draw it. This is what is shown in this case. There's a red blood cell, and inside this there is a blue marking present. This would be a Cabot ring. Cabot rings are usually found in patients of asplenia, though there are multiple causes for them, but yes, one of them. And the second, you can notice a basophilic spot inside the red blood cell that is called as oval jolly bodies. Both of these are features which would be encountered in patients who have undergone a splenectomy. So as such, I would like you to remember asplenia is responsible for development of these two manifestations, in contrast to Pappenheimer bodies, which are described in sideroblastic anemia. And Pappenheimer bodies will be having, in fact, multiple bluish spots like this present inside the RBC. So you definitely can differentiate. Now let us summarize the causes which are responsible for hemolysis. One could be a problem with the RBC membrane. There could be a defect of ankyrin that would result in hereditary spherocytosis, or spectrin that will contribute to elliptocytosis. Another reason can be that the hemoglobin inside the red blood cell can be defective. Hemoglobinopathies that I've explained to you is one, thalassemia, and the second one that I've highlighted is more common in tribal populations or Afro-American child would be sickle cell anemia. Then there could be problem with enzymes which handle oxidative stress like G6PD, but let us assume a condition where none of these problems are present. Not a problem present in the surface of the RBC, no problem inside the red blood cell with respect to hemoglobinopathies. Enzymes are also perfect, but still the red blood cells are getting destroyed. Why? Because there are autoantibodies. The autoantibodies which are causing destruction of red blood cells will contribute to agglutination, Rulex formation, and then subsequently even spherocytes. Autoimmune hemolytic anemia is the next agenda of mine to explain to you, and this would be a two subtypes, that is the warm antibody type and the cold antibody type. The warm antibody type is the one that we will talk about initially, and the antibodies which are present here are immunoglobulin G class. Though this is taught even in pathology, I want you to remember the causes. The important ones are SLE, then is chronic lymphocytic leukemia, where the immuno-incompetent cells will attack the white blood cells as well as the red blood cells. Even in literature of Hodgkin's and non-Hodgkin's lymphoma, I have highlighted regarding presence of autoimmune hemolytic anemia, and then can be drug-induced, that would be alpha-methyl-dopa. This drug was initially mentioned as the drug of choice for pregnancy-induced hypertension, though nowadays we use labetalol. There are four causes for warm antibody-mediated autoimmune hemolytic anemia, but most of the time in the exam, they would love to ask you regarding the cold antibody-mediated one, which is relatively less studied by us. And I would like to divide this cold one into two domains. That is, one would be a pediatric case, second would be adult case. So let's go stepwise for both of them. Well, for the child, I'll be describing a disorder by the name of PCH, that is called as paroxysmal cold hemoglobinuria. There are various triggers that can actually contribute to it. Cold exposure is only one of the components of the disease. I mean, this person goes out in the cold, the RBCs get sensitized, and then subsequently the hemolysis occurs in the warmer parts of the body. When it comes to PCH, paroxysmal cold hemoglobinuria, the initial trigger could be like this child suffered from a pneumonia episode. The organism that was incriminated was Mycoplasma pneumoniae. Now, let us take this to be the representation of the bacteria. Well, on the surface of this bacteria is present a protein, and the name of this I want you to remember is the P protein. Like in rheumatic fever, I taught M protein. Here I'm talking about the P protein. I want you to understand that on the surface of the red blood cells also, a similar kind of antigen is present by the name of P protein. So now comes the trouble. The trouble is that whenever there is any infection in the body, there is antibody production. This antibody will now be confused. Why? Because the actual target of the antibody is to go and target the P protein present on the surface of the bacteria. But because a similar antigen is also present in the RBC, the antibody can go and destroy the self RBC also. If antibody is attacking self, that is why I'm saying this is autoimmune hemolytic anemia developing in this child. So most of the time they would love to ask you regarding the name of this antibody, which I'm highlighting here. This antibody is called as Donath-Landsteiner antibody. The concept is that this Donor-Landsteiner antibody will get sensitized at cold temperatures and then subsequently will cause hemolysis in the body. So I'm describing a child who had suffered from a bout of Mycoplasma pneumoniae already. He's already suffered. He was maybe also treated for the episode of pneumonia. Now the parents went to, let me say, a higher altitude for a small holiday. When this child who has already been exposed to Mycoplasma pneumoniae will be exposed to cold temperature, that is when the problems of the child will develop. Initially, they will think that the child is behaving very fussy because there might be intravascular hemolysis occurring in the child. Initial manifestation could be very non-specific in the form of abdominal pain, or it could be even flank pain, because you see, after all, there's going to be hemoglobinuria in this case. The child will be complaining of cramps or pain in the legs. They could be headache associated. But then what will definitely bring these parents rushing to bring the child to your hospital would be passage of a black urine. I mean, that's not normal, no, because cold temperature per se can contribute to frostbite. It can contribute to chilblains. So initially parents thought the child is sick because he was exposed to cold, जिसको हम हिंदी बोलते ठंड लग गई बच्चे को. But then the passage of black urine is definitely not normal. So in this child, the antibody was sensitized on cold exposure, then caused hemolysis in the warmer parts of the body, and therefore black urine will be a very dramatic presentation in this case. This case demonstration that I mentioned before you is called as paroxysmal cold hemoglobinuria. Now, I don't want you to be under impression that it is only Mycoplasma pneumoniae which is responsible for it. Even other viruses are incriminated, like the one responsible for infectious mononucleosis, that is Epstein-Barr virus. It could be the chickenpox virus, varicella zoster, even parvovirus. Earlier, I have spoken about parvovirus B19 being responsible for aplastic crisis, focal segmental glomerulosclerosis, even erythema infectiosum. Now, one more entry has been made, that is PCH. Now we are left with an adult presentation of cold hemoglobinuria that would be called as cold agglutinin syndrome. In fact, at this junction, I want to highlight the fact that the antibodies which are always present in autoimmune hemolytic anemia MCQs are to be answered as IgG. But for the one that I will now explain to you, where I put the star mark here you will mark as immunoglobulin M class of antibody, and the disease that I'll explain to you subsequently on the next slide would be called as cold agglutinin syndrome. This time the question will begin by describing adult patient. There will be some triggers also. So let us now discuss how cold agglutinin syndrome manifests. This time he will be describing an adult patient after the age of 50 years, and well, the antigen that is going to be involved in this particular case, against which the antibodies will be formed and then the RBCs will get destroyed, will be called as I antigen. I want you to remember this information. Earlier I was saying it was the P antigen. For rheumatic fever I spoke about the M antigen, and now I'm talking about the I antigen, which is common between the red blood cells and the triggers in this case. The triggers can be again Mycoplasma pneumoniae. So again, because atypical pneumonia can be one of the triggers responsible. I mean, why do you call it atypical pneumonia is the reason right here in front of you, that somebody who had a pneumonia is later on passing a black colored urine. Then could be kissing disease. that is infectious mononucleosis. Then can be influenza viruses. So, I mean, I can just draw a list before you, though you don't need to remember whole of it. That could be even cytomegalovirus, HIV. And what is important is to be remembered now that I'm writing. Just like in multiple myeloma, you read about overproduction of the light chains related to immunoglobulin G. I'm teaching a medical disorder which is related to especially cold agglutinin syndrome, that is called as Waldenstrom cryoglobulinemia. Even cryo basically talks about the cold word, right? Cryo basically means cold. So I want you to remember at least two triggers here, mycoplasma being common and then Waldenstrom cryoglobulinemia. Even in this patient, there has to be a history of cold exposures. Like this guy, he went to Rohtang Pass. Now, if somebody goes to Rohtang Pass in the month of December, it's gonna be horribly cold. Lots of time the road might be closed, but if the higher you go up, it's gonna be colder. And this guy was, let me say, not using gloves. He was not using a muffler. He was not using a proper cap. So initial symptoms in this person might look like that of even a frostbite or chilblains, or I would say just what they say in Hindi, thand lag gayi, right? But then you will realize certain manifestations that I'll tell you, which are going to be different from a routine cold exposure. The agglutination of red blood cells in this case will occur at less than 37 degrees Celsius. So cold exposure is definitely required for development of manifestations of this patient. Cold exposure is required for development of manifestations of this patient. Initially, the profile will be that of mottling. Even something like livedo reticularis could be present. The mottling will occur off the tips of the fingers of this person. So initially thought that he's developing frostbite. It could be the tip of the nose or the earlobes. Like I said, he went out in the cold without wearing gloves and protective gear. That is why this manifestation is developing. Lots of time, US doctors might think that this chap is having Raynaud's phenomenon because there might be even cyanosis in the tips of the fingers, acrocyanosis. So Raynaud's phenomenon can easily be misdiagnosed in this case. But then, as I highlighted, one of the very striking manifestations of this guy who's suspected to be having frostbite slash chilblains slash Raynaud's phenomenon is hemoglobinuria. This will be associated with flank pain and extreme fatigue. Lots of time diagnosis might initially be missed because person may never volunteer the fact that he passed a black color urine, and this might even happen in the later part of the illness. Initially the symptoms will be very, very non-specific. So let us now think, what are the tests that would be required for diagnosis of autoimmune hemolytic anemia? This time on this slide, I'm talking about the workup which is required for all these causes that I've highlighted. Let us revise the causes once again quickly, and then I'll talk about the investigation component. I subdivided the discussion into warm and cold antibody mediator. For warm, obviously the diagnosis is easy. He's going to talk about a lady with malar rash or photosensitivity and other manifestations of SLE, blood cancer presenting with cervical lymphadenopathy. I mean, the only blood cancer that has autoimmune hemolytic anemia is gonna be chronic lymphocytic leukemia. On the right hand side, he will talk either about a child or about an adult following a cold exposure. Pathology link to be remembered is the name of the antigen, P protein or I antigen per se. I mean, the word is antigen after all. So either it is M protein for rheumatic fever, I antigen with respect to cold agglutinin syndrome. This is the description that I'm giving you for cold agglutinin. And as I highlighted initially, the symptoms will be very non-specific. So how would you pick up the disorder is what we discuss next. That is overall investigations for autoimmune hemolytic anemia. If you run a peripheral smear in these patients, you might be able to notice Rulex formation, or traditionally Rulex formation is something that we see with multiple myeloma, right? But this kind of an image that I've shown here, very characteristic. Rulex formation post cold exposure or in a blood cancer patient or in a SLE patient should prompt you to think in possibility of AIHA. Then you will also be able to notice spherocytes. Now I have highlighted this earlier in SLA topic. Even now, I mean, when you read about spherocytes in a pediatric age group, it is hereditary spherocytosis. But if you read about autoimmune hemolytic anemia in an adult man, then first thought of yours should be a possibility of autoimmune hemolytic anemia. If you take the blood sample of these patients and you expose it to a body temperature less than 37 degrees Celsius, I mean, as compared to body temperature, the temperature of the sample is less than 37 degrees Celsius, then there would be agglutination of red blood cells developing. You can also do a Coombs test in this case, especially if you are doing a Coombs test, you will read the word direct Coombs test positivity, especially in cases of SLE. And well, what can you do to manage these cases is one, give steroids. I mean, don't give packed RBCs to these guys. Antibodies are waiting to destroy them. It will worsen this case if you give packed RBCs. So you can use either steroids or you can use rituximab. Well, why is rituximab used in this case? Because it will deplete the beta cells, because beta cells are the ones that ultimately convert into plasma cells and produce antibodies. So if you are gonna deplete the beta cells in the body of this person, then the symptom manifestation will reduce. So the monoclonal antibodies which are used here are rituximab and eculizumab, and the primary management for these patients would be given as steroids. After autoimmune hemolytic anemia topic, the next one on the agenda that I'll explain to you is called as microangiopathic hemolytic anemia. Well, what happens here is formation of microthrombi inside the blood vessels. And when red blood cells will slam into these microthrombi, there would be fragmentation, there could be destruction of the red blood cells, resulting in helmet cell formation / cystocyte formation. The disorders where I've described this is discussed in the kidney section. Hemolytic uremic syndrome caused by E. coli O157H7. Then TTP, thrombotic thrombocytopenic purpura. I have discussed these disorders in the kidney section. The third entry that I would like you to remember here is eclampsia. I also want to bring to your notice the fact that nowadays we do not prefer putting metallic heart valves. We prefer rather heart valves made of biological material. But if he says the word metallic heart valves, then the shear stress of the opening and closure of the leaflets can actually cause damage to the red blood cells. Now, when I say the word heart valves, it is not actually the blood vessels which are causing a problem. It is the leaflets, metal leaflets, which are causing a problem. So sometimes he might just try to trouble you by English by writing the word macroangiopathic hemolytic anemia. So I just want you to get the words right. Microangiopathic hemolytic anemia, the traditional answers are gonna be hemolytic uremic syndrome, TTP, and eclampsia. Actually, in the textbook, they are given on the same page. So the impression is that all are examples of microangiopathic hemolytic anemia. Fine. But the point is, lots of time he might just use English to his advantage by saying the word macroangiopathic hemolytic anemia is related to, then the answer would be metallic heart valves. So the types of anemias that I've explained to you is one's related to hemoglobinopathies, then is related to defects on the surface of the RBCs, defective enzymes inside the RBCs, then no problems, but antibodies coming from outside, resulting in extensive Rulex formation and spherocytes with positive Coombs test. Then I've spoken about rather microthrombi causing fragmentation of the red blood cells. So these are the various types of anemias that I want you to remember, and I would like to finish the discussion by quickly mention some abnormalities of red blood cells in slides that can be given to you in image-based questions. In both of the images that you can see at the moment, you can notice spikes. You can notice spikes on the surface of the red blood cells. So now I will tell you a hack how to remember it. You will notice that in this case, the spikes which are present are rather asymmetrically present, whereas in the second image, you will notice that the spikes are equidistant from each other. Because in the first image, in the red blood cells, there are definitive spikes present. I'll write spikes common for both of them. Spiky RBCs is what I'm talking about. But in the first case, the spikes are asymmetrically placed. So this red blood cell would be called as a acanthocyte. Whereas you can notice the fact that in the second image, the spikes are symmetrically placed. These symmetrically placed spikes will give you or help you identify, or rather I can use another term, equidistant from each other, or almost equidistant from each other. So the word is achinocyte. Well, why is acanthocyte more frequently asked? Because he wants to hear about this medical disorder by the name of A-beta lipoproteinemia. Though you read about this term in biochemistry, I want you to be aware of two aspects related to A-beta lipoproteinemia. The first one is obviously that acanthocytes are present. Second, cholesterol and triglycerides are reduced in the body of these patients. I mean, normally we always study conditions where serum cholesterol and serum triglycerides are spiking. But in this case, I said it is cholesterol and triglycerides both reduced along with the abnormality of the red blood cells. So acanthocyte echinocyte comparison should be remembered. Then you can notice a RBC which is lacking a central pallor. So this is one that is called as a spherocyte, and there are multiple disorders where spherocytes have been discussed. So let's just recall them. Hereditary spherocytosis, chronic lymphocytic leukemia, autoimmune hemolytic anemia. In fact, lots of causes of autoimmune hemolytic anemia that you should be familiar with can be squeezed up in the discussion. also, I don't want you to miss up between a bite cell versus a schistocyte. I mean, I've shown a deliberately enlarged view. The bite cell would be like somebody's eaten into a apple, whereas the last one that has been shown earlier also will be looking like this, a ghost of a cell. Like I'll say a ghost of a cell because the cell is busted, it is destroyed. This would be a helmet cell or a schistocyte, which you traditionally read with hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. So these are a couple of images which I want you definitely to remember with respect to the different abnormalities of the RBC. And well, keep on learning, guys. Keep on adding up more facts to your knowledge. In fact, study this with pathology so that you can definitely be having an edge over others. And hemat is one part that is always asked in the exam, and you need to score 100% in that. I mean, a question of hemat goes wrong in the exam, it's a disaster, because in a sense that you see everybody else is gonna get it right. So keep the focus on, guys. Keep learning new facts. Thank you so much for hearing me out.